everyone, and welcome back from the break. I am aware we are starting bang on 1 o'clock. So I'm just going to slowly and tentatively introduce everyone on the panel on this next session, which is session 4, in what are we seeing in long COVID clinics. And we have got a real mix of people on the panel today because we wanted to try and cover everything in, but it is supported with a 1-hour special on this YouTube platform, which talks about everything from fatigue management and breathlessness and the relationship between breathing pattern disorder. So I'm delighted to introduce the panel, and first of all, my co-chair. So Kola, if you'd like to introduce yourself and just tell us a little bit about you, please.
Thanks very much, Richard. My name is Kola Akinlabi. I'm a clinical specialist in respiratory physiotherapy, and I'm a lead in Barnet in respiratory team. Currently, I'm the clinical lead for LongCOVID in Barnet, working in LongCOVID with an MDT specialist team at the moment.
Thank you, Michael.
Thank you. Thanks very much. So I'm Mike Zandi. I'm a neurologist at the National Hospital Neurology and Neurosurgery in Queen Square in London. And I provide a bit of input into the UCLH long COVID clinic. It's great to be here. Fantastic day.
Thank you very much. We're so excited you're here for sure. Thank you. Rebecca, coming down to you.
Thank you, and thanks for inviting me. So my name's Rebecca Livingston. I'm a respiratory physiotherapist, and I'm the clinical lead physio with the integrated post-COVID service at UCLH. And my background's in kind of respiratory medicine and breathing pattern disorders.
Thank you so much. Penny, over to you.
Hi, I'm Penny Fershman. I'm a clinical lead occupational therapist in critical care with expertise in post-ICU syndrome. I also have long COVID, and I've been off work for 11 months with long COVID, so I'm here more as a patient, but do have knowledge of fatigue management and things from previous illnesses as well.
Yeah, so I'm delighted Penny's here. You're a bit of everything today. You're a co-chair, you're an expert OT, and you are representing the long COVID community. So, and you're a carer as well. So I'm really grateful for you to be here. Julie, over to you.
Hi, yes, thanks, and me too. My name's Julie. I'm a respiratory physiotherapist, and I also have a special interest, a bit like Rebecca, in helping patients manage breathing pattern disorders. I work for Inspiratory, and we've been able to run some post-COVID rehabilitation programs, which I'm excited to tell you more about today. I also help athletes with breathing pattern disorders up at the Institute of Sport, Exercise and Health. I should also say that Natalie Hilliard unfortunately couldn't be with us today. She's a physio who I work very closely with. She's a co-founder of Physio for ME. So I'm sort of representing her too as well.
Thank you. We're going to move straight into the first presentation. We're going to have all three presentations, questions at the end. Again, just a reminder, we have a whole session with occupational therapists at the end on vocational rehab and return to work planning. And we also have the fatigue podcast and the breathing podcast separately as well. And we're going to try and be as inclusive as possible here. So Rebecca, coming down to you for the first presentation, please.
Okay, just share my slides. So are they sharing?
Yeah, perfect.
Brilliant. So I'm just going to tell you a little bit about our integrated post-COVID service at UCLH and sort of what we're seeing really. So we originally started out our clinic actually in a van on the street last May because our outpatient department at UCLH was closed. And from the beginning, we were taking referrals both from patients who were admitted to hospital and then discharged from our hospital, but also patients who were referred in from GPs in the community and people who had attended the emergency department and not been admitted. So we've been seeing a mix of hospitalised and non-hospitalised patients from the beginning. We have an MDT clinic, both in terms of the core clinic, which I'll tell you a bit more about, and then the wider support, which you'll also hear a little bit more about later as well. So Melissa Heitmann is our clinical lead for the service, and we've seen well over 1,000 patients so far in our clinic, and a huge number of those, so around 700 face-to-face. We're very lucky to have a service that's integrated with community services within North Central London. So we have people from the community teams joining our clinics, and we've worked to sort of smooth the pathways across from the clinic into community services for follow-up care. I think early on, when we were setting up the clinic, it was a real unknown as to firstly what the need was going to be for the patients that we met, but also what the offer was going to be in terms of follow-up services. And so right from the beginning, we had to kind of map what services were going to be available for us to refer into. We were very aware that we couldn't start assessing patients and asking about their needs without then having somewhere to be able to offer follow-up care. And we also knew that there was going to be a lot of different specialists needed in this patient group, but equally we couldn't have everybody in clinic. As you can see, the van was very small, and so we really, as therapists, we were working to screen for sort of on behalf of multiple different allied health professionals. So the clinic is now, thankfully, not in a van anymore, and we're in an outpatient setting, and patients will come in for to see both the doctors and the physiotherapists in clinic, and they'll have certain investigations, things like chest x-rays, blood's done, and a consultation with the doctors, and then they'll see the physiotherapist, and I'll tell you a little bit more about what we do with those patients as well. So our therapy assessment kind of screens for a large number of symptoms. So that includes breathlessness, fatigue, difficulties in terms of cognition with concentration and attention span. We ask patients about how they're coping with the new burden of their symptoms, both in terms of their mood and anxiety. We ask about whether they're back to work. And we carry out some outcome measures with our patients. So we use fatigue assessment scale to measure fatigue, a dyspnea 12 to measure breathlessness. We do a BPAT, which is a breathing pattern assessment and tool, which I'll tell you a bit more about later, as well as using a PHQ-2 and a GAD-2 to kind of screen for mental well-being needs. And we are also doing an exercise test in the form of a sit-to-stand test, which you can see here in this photograph, to look for desaturation and just see what people's heart rates are doing in response to exercise. So as well as kind of collecting then all of that information, we're sort of based in clinic rooms next door to the doctors, and there's a lot of conversation back and forth to be able to work out who is safe to begin rehabilitation, and then where the best service is to be seeing people. So we're giving some advice out in clinic, and then we are referring patients, depending on their needs, either into services within the hospital or community services for their follow-up care. So a little bit about what we are seeing. So COVID is a multi-system condition, and I have to say that every week I'm in clinic, I discover new symptoms that people are experiencing, and we are definitely seeing different phenotypes of patients. So patients who present, can present very, very differently. We're definitely seeing patterns in the way people present. But we've done a little bit of analysis of some of the patients that have been through clinic, looking at sort of the data that we have, and we're looking at 321 of those patients that have come to clinic sort of relatively near the beginning. We looked at dividing those patients out into sort of hospitalised and non-hospitalised patient groups. And we were seeing that fatigue and breathlessness was significantly lower in the patients who have been to intensive care than the patients who have been referred in from the community, and that more people in the non-hospitalised patient group were presenting with breathing pattern disorder, and that of the inpatient group and the hospitalised patient group were also more likely to desaturate on their exercise test. So that's just to give you an idea kind of the patterns that we've started to see in clinic. And we're working to kind of map some of those phenotypes, and there is a lot of sort of blurred lines. There are people who have been in intensive care with long COVID, and there are people in the community with that long COVID type pattern of symptoms as well. So just to talk a little bit about breathing pattern disorder. So I guess I don't know how much this is sort of known in the community about breathing pattern disorder, but this is when we see people who have got a disordered pattern of breathing that is not being driven anymore by an organic cause, or is in excess kind of their metabolic needs. So, particularly in patients post-COVID, it's a respiratory illness that affects the airways when you're unwell. And so it's sort of expected that your breathing pattern would change at the time. But as you recover from that acute illness, your breathing pattern should recover as well. But in some people, we're seeing that that's not the case. And looking at our data, we're seeing that 23% of our patients are presenting with breathing pattern disorder. And that causes symptoms of breathlessness, chest tightness, can cause dizziness, and can contribute, I think, also to that brain fog that some people are experiencing as well. So it's causing sort of a wide number of symptoms. And we have started doing some virtual breathing pattern retraining with this patient group. So just on the left is a breathing pattern assessment tool, and I need to put out a complete disclaimer here in that along with Lizzie Grillo, I was part of the team that developed this breathing pattern assessment tool, and it's not been sort of robustly validated. A reference to the paper at the bottom there that where it was first described as being used in patients with refractory asthma. But we are finding this as a useful tool for people who are sort of not specialists in diagnosing breathing pattern disorder. There are a huge number of people that need this assessment, and this is a useful tool for people who are kind of fairly new to seeing this, to be able to look at someone's breathing pattern and see whether they've got suggested sort of features of breathing pattern disorder. So we have started virtual breathing pattern retraining with patients, and just in our first patients who have been through that program, we are seeing that there is an improvement in people's breathlessness and their breathing pattern with sort of between 3 and 4 sessions over video, and I think Julie might touch on that a little bit more soon. And I guess the other thing that we're also finding that's been really interesting is this relationship with fatigue and the interplay between those. So we're seeing a lot of people with kind of post-exertional malaise or post-exertional symptom exacerbation, and a sort of a very relapsing and remitting picture, and that for some patients exercise hasn't been helpful. That's not to say that's the case for everybody, but we've definitely become more cautious with how we look at exercise and activity in this group. We're seeing people with sort of autonomic type symptoms, and we're seeing a lot of people who are really struggling psychologically with the impact of their new symptoms. So people who really can't fulfill their previous roles, either as parents or in their work, and that takes its toll. And one of the things we're really promoting in clinic is kind of the self-compassion that needs to be present for people to build some acceptance to the way that these symptoms are affecting their lives, and that we are there to support people with this, because it really is significant. I hear people saying to me, oh, I feel like I'm lazy, and that's absolutely not the case. We are seeing some people with high lactates and slow lactate clearance when they're walking. There is a pathophysiology sort of underlying these symptoms, and so I guess just to reassure people that it's not people feel like maybe it's in my head. It's absolutely not. We're very conscious of the fact that it is being driven, and it's a complex interplay of symptoms that we're all kind of working to address. And I guess one of the kind of takeaway messages from that is, really not to try and push through symptoms when you're trying to recover, is to really listen to those fatigue symptoms. And you'll probably hear a little bit more about that as we go on this afternoon. So you can see here, so this is Melissa Heitmann, our clinical lead, and Helen Purcell, one of our physiologists down there on the slide with a patient. So I guess the things to finish up with is that I think we haven't seen as many kind of frightening findings as we maybe thought we were going to. I think when we set out, we thought we'd see a lot of PEs in people that were undiagnosed, and we were very worried about what was sort of driving symptoms for patients. And so we haven't seen that anywhere near as much as we thought we would. It's a really fascinating area to be working in, and kind of learning new every week seems to be moving on in leaps and bounds. We're seeing some new lung disease, we're seeing some new asthma. Dr. Zandi, I think, will talk to us in a minute about some of the neurological things that are being seen as well. And we're lucky enough in this clinic to have a wider MDT of support. So patients that are needing support from specialists, where we have a virtual meeting once a week where people from all different specialties can feed in to discuss patient groups. And that's been such a brilliant place for us to be able to ask questions about people's presentations and understand what's safe to be doing. People are getting better. It is slow and it is frustrating for people. For the people who are perhaps struggling more are places where people aren't able to reduce their activity in the same way. The people who we're seeing getting better, it really is taking time, but it is happening. And there is a lot of interplay between symptoms, breathing pattern, fatigue, and that support for people's psychology is also really important. So a joined up MDT approach is really important to kind of answer those unknown and unanswered questions. And that's kind of what we're seeing in clinic, and I'll finish there.
Thank you, Rebecca. As always, an amazing presentation. We are going to move straight on to the next speaker, and we're going to go for questions at the end. So I am delighted to introduce Julie. Julie's going to just be speaking to us about more things respiratory and fatigue as well. You're going to do a combo, aren't you? So over to you, Julie.
Yes, thank you. Hopefully my slides are up okay.
Perfect.
Brilliant. Okay, so yes, I'm going to tell you about this program that was created through a collaboration between myself, a physiotherapist, as I said before, a member of the Physio for Breathing Pattern Disorder Committee, but also Natalie, Physio for ME. And both of those have really amazing websites if people would like to know more specific information. Please visit those websites, but also with the psychological wellbeing teams from Bexley, Mine and Greenwich Time to Talk. This programme was commissioned by South East London Commissioning Group, specifically Greenwich and Bexley, run through Respiracare. And it was an eight-week educational programme. So I just want to kind of go through what we did with the patients, what we found. So the patients were referred to us with breathlessness, fatigue, body pains. They were the sort of main three symptoms, referred by GPs, secondary care. The idea was that they were medically optimised. So they had ECGs, they had echoes, CT scans, some had LFTs, not all of them. But the idea was that it had sort of physiological treatment completed. They were assessed by myself, physiotherapist, with a very lengthy subjective assessment. I say lengthy, it was digital, it was an hour. All of the outcome measures you can see down at the bottom there were done via digital questionnaires. So I didn't have to worry too much. They were already done pre. I was very aware of not, exacerbating fatigue with these patients. And I think that it was a really powerful time for me to really listen to what they were saying and enable them to tell me their story and really get a feel for what was happening with their fatigue around any potential post-exertional malaise. So any disproportionate symptoms, whether it was that brain fog or pain or the physical sort of fatigue, anything that seemed disproportionate to what they were doing. And you can imagine there was, I would say, a lot of them had signs of this. So we had to tread carefully. We chose not to do an exercise test. We did have the sit-down 1-minute test available. I did do it on one patient who I thought was stable enough fatigue, but I didn't feel it was appropriate for these patients. So we're talking about 85 patients that we got through for the first 3 months. And as Rebecca's talked about, the breathing pattern assessment tool we performed also digitally, which is fairly simple and just takes a few minutes and is a real eye-opener for the patient when you explain to them, you know, the difference in their breathing and what it should be. I know that those outcome measures aren't necessarily validated. We don't have any validated questionnaires as such for patients living with long COVID. So we sort of had to choose the ones that we thought best represented what we were trying to help these patients with in terms of looking at their fatigue, looking at their hyperventilation, possibly anxiety, depression, respiratory symptoms. So just to run through the 6 sessions that we delivered. Session 1 was very much educational around explaining to the patient about the autonomic nervous system, explaining, as Rebecca said earlier, about the overactive sympathetic nervous system when they were suffering the virus, and how potentially is that part of the nervous system switched off again, or is it continuing to drive? Have they lost sort of their ability to rest and digest the parasympathetic side? So it's really nice to be able to present to them some physiological reasons as to why they're experiencing what they're experiencing. Also, within the first assessment, I would have got them started on their breathing retraining, possibly doing some work on looking at measuring their control pause, which is a measurement of drive to breathe. And it's quite interesting to see someone with a low control pause usually has a degree of dysfunctional breathing. So it was another measurement which I think helped. It's quite subjective, and not all patients did it, but it was another tool that we could use to help patients guide both where they're at and whether they were improving. From that first session, we got them to perform or keep a diary. So not just physical, but everything: sleep, nutrition, what they were doing, how they were feeling, basically anything they possibly could. And then the second session was all about looking at those diaries and really reflecting on what they were doing. And I think what was so powerful, although these patients presented with potentially quite different experiences, there was a lot of similarities, and that was really powerful for them to experience and hear other people's stories about the boom bust, about trying something that seemed really simple, really simple. One patient said to me about wrapping Christmas presents, and that was it for the rest of the day, you know, a 15-minute activity. And I think that there was a lot of empathy enabled with the other patients and myself as well, to be able to really appreciate the devastating effect this is having on people's lives. Session 3 was about the things that might be stopping people to recover. So respiratory things, a lot of patients were getting recurrent respiratory infections. So it's more about, chest clearance, bronchial hygiene, the importance of nutrition, eating well, and sleep. You know, these patients were telling us that they're not sleeping, they were really struggling with sleep. So anything we could do to help them with providing some information about helping to create new good sleep habits, where that sleep was so disturbed for quite some time. Session 4 was with the IAP team, which was great for them to help people understand the symptoms of anxiety and depression, which I think sometimes some of the patients were quite surprised about, but introduce them to this idea of post-traumatic stress disorder as well, which I think quite a significant amount of them were experiencing. I should just clarify here the type of patients that we were experiencing. These 85, 10% had a hospital admission and 90% didn't have a hospital admission. They were at home with the COVID flu-like symptoms. I do that for the flu-like symptoms that they were experiencing for 3, 4, 5, 6 weeks time, and they're all in the phase 1. We didn't talk about exercise until session 5, and that was really important because the whole point of the program was about finding stability. It's about establishing whether they were able to do exercise. So, you know, it was absolutely important that they had an individual feedback as to where they were. They had some people that were not doing exercise at all. Some people might be just trying a 10-15 minute walk. Some people might be trying some very gentle yoga, but they would literally be trying it and then watching what happened afterwards to look to see whether what symptoms might have exacerbated from it. So it was very individualized, but also the importance of breathing and moving around too. We did have a couple of patients that were appropriate for me to start on some inspiratory muscle training, which was another way of being able to sort of provide a loading mechanism to the respiratory muscles, which can have an impact on breathlessness. But it was only done with those that had a really good breathing pattern, were able to cope with that level of activity. But it was another nice way, which was really beneficial for the patients to be doing something, even though they might not be able to go and do their 40-minute walk they did pre-COVID, they were able to do something as simple as this, which was really effective. And then the last session was to summarise. I just want to add that at every session we tried a relaxation, a different relaxation technique with them. I think it's absolutely important that we were able to demonstrate different relaxations, because we know it's a bit like exercise. You know, one type of relaxation doesn't necessarily work for the next person. So the Laura Mitchell technique, the Jacobson technique, we did some hypnotherapy with them, some mindfulness, and so each session they were able to experience something and then go away and practice it, which I think was really powerful for them. And as I say, it was really about finding stability. Have they recovered from one day to the next? And what we were able to do was actually assess, only on 10 patients, so this is anecdotal, but it was really interesting. We were able to provide a 3-day monitoring of the patient's heart rate variability. So basically that's a measurement of the autonomic nervous system, looking to see what was happening between the sympathetic and the parasympathetic nervous system. And just a quick overview on heart rate variability, what it is it's an indication of how balanced the body is with the sympathetic and parasympathetic nervous system. But the lower the heart rate variability, the less ready the person is to exercise. Heart rate variability is measuring the time between the heartbeats. And so when the heart beats very rhythmically and on time and there's no variability, that means the sympathetic nervous system is more overactive. When the heartbeat there's variable time between the heartbeats, that's when the parasympathetic nervous system is more dominant. And it's kind of, I always sort of think about it being a little bit more chilled out. It sort of beats when it fancies it. And obviously the heart rate variability is similar to heart rate. There's genetics involved and things, but it's what we thought was it could potentially be something that could help us understand whether the patient was ready to exercise or not. And I wanted to show you this slide of an example of someone that has a good balance. So this is a day, okay, where they're measuring the heart rate variability in the daytime. You show that the red is the sympathetic nervous system, which is what we would expect. And then at nighttime, there's the parasympathetic nervous system, allowing the person to rest, recover, move on to the next day. Heart rate variability is 125, which is at the top really. Let's have a look at the next slide. I should say we had the expertise of Info Ground and Air helped us with this, and it was done with lifestyle beats monitors. But here's a COVID patient with long COVID. Look at that sympathetic nervous system is pretty much active. That person actually, you might be able to see this. This person had a green face, like a happy face that they felt they slept well for 8 hours. That sympathetic nervous system didn't switch off all night long. Heart rate variability is in its boots. It's 11. This patient is not ready to exercise. They have not recovered from one day to the next. And I think that this was really powerful for us to be able to really see this and validate the person's symptoms, which we were able to show them. So, as I said before, Natalie was able to run the second and fifth session with me. So Natalie Hilliard, the fatigue specialist physiotherapist, and she spoke to the patients about how it was a real methodical process, a step-by-step process of finding stability. And she has this lovely slide that talks about bumps in the road. You know, there's always flare-ups and setbacks, and that was really important for the patients to be able to tell us that and then reset them and get them back onto track. And it's only then that you can then think about, when they've stabilized it, you can think about exercise. But it wasn't just about physical exercise and physical fatigue. I think that's the one that we're sort of mostly aware of as physical therapists, myself anyway. What I rapidly learned about is the impact of social fatigue, cognitive fatigue and emotional fatigue. So even saying to the patient, that telephone call with your friend for half an hour could be contributing. So it was absolutely essential from their diaries that they were able to start working out what sort of stimulus was causing their fatigue to flare up. But also, you know, in terms of resting and recovering, you know, if your breathing pattern is not optimal and you're breathing inefficiently, we know that you can breathe up to 30-40%, use 30-40% more energy. That's not going to help. If you're trying to rest and you're not breathing properly, you're not going to recover. Absolutely essential. So we talked a lot about the nose and the importance of nose breathing, gateway to the immune system. So those patients still get in the cycles of respiratory chest infections, absolutely essential. Importance of the diaphragm, making sure we had a lovely presentation this morning on VQ fusion, you know, how the blood's at the bottom. Well, that's where the air needs to go. It's a waste of time putting it at the top, and that's really important for these patients to be able to correct that. And how basically breathing is quiet, it's rhythmical, it's 8 to 10, 12 breaths per minute. Tidal volumes are much smaller than you think they should be, and basically it should be regular, rhythmical and relaxed. And if anyone wants more information, there's a website there to look up more about breathing, and there's some videos there on how to breathe, how to assess your breathing. But as you can see, the big part of this program is about rest and relaxation. And we use that analogy with the mobile phone. You know, the mobile phone that's not, you know, you forget to switch the switch, doesn't, you know, you wake up and your heart sinks when you see it's 10%. That's what these guys were experiencing. They were not recovering through the night. They were not able to rest, recover and move on. Although there were some of them were trying, they were still trying to work. Some of them maybe trying to do some exercise, coming crashing down, really stuck in that boom bust cycle. And I think when we often said to people, so how do you relax? And they say, well, I watch Netflix or I go on Facebook, and it's like, that's not relaxing. That's not allowing the parasympathetic nervous system to reboot and really allow the heart rate to come down, heart rate variability to go up, and really allow it to recover. So it's really important for people to understand. So just a couple of slides to give you some pre and post with the heart rate variability work. So this is an example of another patient that we measured pre-rehabilitation. As you can see, very lack of green going through the nighttime, so dominant sympathetic nervous system. But we're also able to look at, over the 3 days that we measured this person, we were able to look at energy resources. And you can see from that graph there that the energy resources in the 3 days that we measured them before the program were actually less than when they started the 3 days. So we're finding that people they were trying to, this particular person was trying to work, was trying to see whether they could go for a walk, and they were actually just making things worse. The energy resources were not rebooting. They're not able to exercise. So then this is post-rehabilitation. Amazing to see a massive improvement in parasympathetic nervous system, sleep improved, heart rate variability improved. This didn't happen in all patients, I must say. This only happened in a couple of patients. This is, as I say, anecdotal, but it was a really lovely tool to be able to show this patient that, the strategies they put into place had really worked. And you can see their resources increased from the start as well. So we're able to, this patient, we pulled back on their exercise, but we were able to then start to rebuild them. I just want to show you the slide about outcome measures. We saw some great improvements in terms of psychological well-being. We know as physical therapists with people with physical problems, the impact this has on psychological well-being, and there was some improvement there. But it was also identifying those that perhaps didn't have, still needed more psychological support. So it was enabling us to refer on to the IAP service. The big one on this, I think, was the mastery in the CRDQ. This is a measure of how well people cope with having a lung disease cope with having long COVID, and the strategies that you can use to help you to cope with having those symptoms was really powerful tool that I think we gave people. So just my last 2 slides, I just wanted to show this program wasn't a curative program. This was very much about us being able to put people on the right pathway, to show them light at the end of the tunnel, to identify those that perhaps fell out of those, the strategies that we were putting in place that didn't respond to that. And it's those that had evidence of orthostatic intolerance that needed referral onto cardiologists. It was those that perhaps had more symptoms around. We had some patients looking at possible post mast cell activation, so referring on to get some HC1 antihistamine treatments. And I know the dietitian talked earlier on about care with antihistamine diets, so referral onto dietitians too. Psychological support, speech and language therapists spoke this morning. Really important that we identify as physical therapists that we can move. We can be we can refer these patients on. We can be the ones that really help to direct these patients and have a voice for these patients to be able to get them the right treatment. And just to finish, we had some lovely feedback from the patients, just to sort of reiterate that although this is important that we treat these patients individually, that the group environment was really beneficial. And, that they found that the not being alone in their journey was a really powerful thing for them to experience.
Thank you so much, Julie, and we will be taking questions at the end. Thank you. Great data. We're moving on to our final speaker. Michael's going to be talking to us about his speciality area, and there's so much interest in this, Michael, so thank you so much. Over to you.
Thanks so much again for the invite. Can you see my slides?
Yeah, perfect.
Great. So I'm really happy to be here, and great privilege to be here. It's really, I'll talk a little bit about what the UCLH clinic does, and we have our own LongCOVID National Hospital for Neurology and Neurosurgery clinic too, but it really is a big team effort. And I've really enjoyed today's talks. I do work with Ami Banerjee, and I've got no conflicts of interest related to this talk, though I am interested in putting in applications for research into LongCOVID. I was struck by Asad Khan's talk, and I completely agree that we really don't know what is going on. And I think that's one of the key messages, and it's very humbling. But certainly in neurology, we're just starting to learn what are the effects on the brain in LongCOVID. And we still really haven't learned about the effects of the brain from the first wave for hospitalized patients. And that's some research that I'm involved with. So we've got a clinic that's here at Queen Square, which is part of University College London Hospital. This is the National Hospital for Neurology and Neurosurgery, and the grey building behind it is the Institute of Neurology. And that's where I've been based for a few years. And I've had an interest in neuroimmunology, and also patients who have antibody-related disorders that can cause thinking problems, cause psychiatric type symptoms, cause psychosis and anxiety, where we found autoantibodies and other things. So there certainly is an overlap between neurology and psychiatry. We have neuropsychiatry, and we definitely work together. We've had extra funding for this clinic from the National Brain Appeal that I'd like to acknowledge, which has helped me and also a consultant colleague, Dr. Patricia McNamara, who's also a specialist in autonomic nervous system disorders and is seeing the bulk of our patients now with LongCOVID. So in July last year, we reported patients who were hospitalized with COVID, who had neurological effects. For the past 4 years, we've had a monthly meeting with neurology, virologists, infectious diseases doctors, allied health professionals, neuropsychology, physiotherapy. And we'd been looking at patients with suspected encephalitis or brain inflammation. And half of that can be infectious, and half can be the immune system, often triggered by infection. And in the first wave, we shut the meeting down because we thought it was such an esoteric thing. And a lot of our fellows and staff were being redeployed back in March last year. But very quickly, within the first couple of weeks, we had lots of notifications coming in of patients in hospital who were confused for a long time, often young people. They may have had some chronic hypoxia, and they were encephalopathic, or you would call them delirious if they were older patients. And the terminology there can be difficult. And that seemed to be quite common, perhaps 20% of patients who are admitted. But then we were really focused and biased, and certainly our data is biased due to referral bias of the most severe cases. But we were seeing people who had confusion, antegrade severe memory disturbance, sometimes with seizures, and that would be encephalitis. So for example, the patient at the top here had an MRI scan very similar to what we see in autoimmune encephalitis, and that was linked to COVID. And thankfully, this has been quite rare. We did see an increased incidence of an encephalitis where you see white matter injury, or ADEM, we call this acute disseminated encephalomyelitis. And we also very rarely saw situations where there was necrosis of the brain and perhaps viral infection. In summary, we had this large group of encephalopathy. We had those with definite inflammation within the brain. I haven't shown, I'm not going to talk about strokes, but we've certainly seen strokes, cerebral venous sinus thrombosis, and people having really aggressive clotting of the blood. And we also saw peripheral nerve problems, the Guillain-Barré syndrome, though actually in retrospect, we haven't seen in the last year an explosion in the number of cases of peripheral nerve involvement to suggest that this is a significant secondary effect of COVID. And then we've seen miscellaneous things, spinal cord problems, visual problems, optic nerve problems, demyelination and things like that. And this is the study, a UKRI funded study that we're part of, which is a national study to look at those who were in hospital. So what are we now seeing in the clinic? So we see people who were referred because of serious neurological effects, like those that I've mentioned from around the country. We're a national clinic, but we're also very much part of the LongCOVID clinic in UCLH. And we attend the weekly MDT with them. And we also have this, our own standalone clinic. And because we really don't know what is going on and want to avoid premature judgment of what the situation is, we very much favor investigation and to try to really get to the bottom first of, has there been neurological involvement? And these are patients who have got prominent ongoing neurological symptoms, such as those with long COVID. And we are seeing those with prominent cognitive symptoms, so severe brain fog that's ongoing, sensory symptoms, numbness, weakness, balance problems. And what we need to do in neurology is certainly listen to the patient and then examine. And it's one of the challenges early on has been the difficulties of having face-to-face clinics, but we certainly try to see all of our patients face-to-face. And then we use targeted investigations with MRI to look at the brain or the spinal cord, neurophysiological tests, which include brainwave tests, but also nerve conduction studies for those who have neurological signs and sensory motor symptoms. And then we've tried to look in more detail at the pattern and nature of the memory with detailed neuropsychological testing. And this involves tests to look at the ability to concentrate and process information. And I think that is one of the key patterns that we are seeing, and I think is one of the strongest signals with people who report brain fog. It's that concentration difficulty, processing speed, the ability to get information in. And it's very much related to post-exertional malaise. And also, as Julie was just saying, preventing cognitive fatigue is certainly something that can be helped there. But it is also confounded by anxiety, mood, fatigue, and other problems. We also look at focal neurological deficits in memory, so the anterograde memory, the ability to take in information and then hold it and then rehearse and recall that information after 5 minutes, after half an hour also. And also language. We've seen people have specific language and speaking disorders. The clinic also has access to a national autonomic service that my colleague Patricia McNamara and Valera Iodici work in. And in some patients, we do feel that we need to move on to more invasive tests. So far, I think what we've been seeing is long COVID seems to be a systemic disease. It's not necessarily a lung disease. It's not necessarily a brain disease, but there does appear to be systemic involvement, and perhaps there's ongoing inflammation in the body or metabolic or other processes going on. And we really benefit by being part of an MDT, working with our respiratory colleagues, cardiology colleagues, autonomic colleagues, which we do once a week. And we still have our weekly encephalitis and COVID national meeting too. We are identifying secondary phenomenon. So we do see migraine, we do see vestibular migraine, vestibular symptoms. There is an extra clinic for people with prolonged loss of sense of taste and smell. And we do see concomitant anxiety, depression. We have seen people with PTSD, and I think that's important to be identified and treated. But it's important to emphasize that these are secondary phenomenon, and there is clear to see biological processes going on. And I think what we need to do urgently is to have research embedded with patient-led research embedded into our clinical services to try and apply treatments. And I think my own view is randomized controlled trials of the various agents that we think may work. Perhaps there's an ongoing tail of inflammation, is really what's needed to be able to know how we can reduce the symptoms, shorten the time to recovery, and prevent any risk of long-term damage. So, for example, this schematic is quite a nice one, and I think the bulk of what we're seeing is the systemic effects, maybe systemic inflammation. We know there is an effect on blood vessels and the autonomic nervous system, and I think this can cause neurological symptoms, sometimes in the absence of brain inflammation itself. We think rarely the virus can get into the brain, but we really haven't got a good handle on this in long COVID. There can be muscle involvement and nerve involvement, which can manifest in fatigue and exercise intolerance. And I think what we have seen a lot in our hospitalized patients is something that looks autoimmune after the virus. There seems to be a little bit of a delay, and then there are significant effects. Are there autoantibodies? Are there cytokines? Are there other things? We need to try to find and select the patients who benefit from treatments for those, because the treatments on their own could be harmful. Of course, in the headline last week, we have this study, which was of a large study of American healthcare records, so very low resolution data, where the headline is 1/3 of people with COVID can have a neurological or psychiatric diagnosis in the following 6 months. 1/10 of them for the very first time, their first diagnosis. And also, compared to other viruses, the incidence of anxiety and depression, but also dementia, is higher with COVID than it is with, say, other viral pneumonias, other people who've been to ITU. So there appears to be something biological about COVID, something it does to the body that could lead to these problems. Of course, the incidence of dementia is a concern, and it's difficult to know whether this is just we've stressed a significant portion of the population with a virus, and you will therefore accelerate the diagnosis of a dementia process in those in whom you would have found dementia in the following year or two. But could the virus cause long-standing effects to the brain is something that we do need to look at. For example, one thing that had been of concern last year was, are we going to see an epidemic of encephalitis lethargica and brain disease after the pandemic? And well, to be reassuring, we haven't. Given the large numbers of people who've had COVID, we haven't seen people coming into hospital with Parkinsonism, dementia, cognitive failure in the young, or brain atrophy. We just haven't seen that in large numbers. Of course, there have been a handful of cases, and then we need to be clear on attributing, is this really due to the virus or not? And this is where research is involved. It's a slight aside, I do strongly recommend this book, Encephalitis Lethargica, The Mind and Brain Virus, by the historian Paul Foley from Sydney. And there's also this book by Joel Walensky, Encephalitis Lethargica. I think there are lots of interesting stories, again, very much patient-led. The Joel Walensky book also had physicians and others who'd had encephalitis lethargica writing about their own symptoms. And the book by Foley tackles how society responded to a large number of people who had new onset disease, and actually how patients and legal challenges could help improve healthcare for them. So this is one study. We haven't analyzed all of our cognitive data yet, but this is a study from colleagues in New York and Columbia with permission, looking at brain fog with time. And I think this is an interesting study to first of all show, in a relatively short follow-up period, there's a small proportion who have fully recovered. So many people have got ongoing symptoms in terms of their brain fog. There are a proportion of significantly improved. And we are certainly seeing those who have completely improved too. One of the things of note is there seems to be a delayed onset before this comes on. And that's certainly anecdotally something I've heard a lot of someone who has moderately severe COVID at home, get better. So this is not bad COVID, admitted to hospital, admitted to intensive care unit. These are often patients who've not been into hospital, get better, and then 2 to 3 weeks later, the symptoms kick in. And I think one possible mechanism of that may be the immune system, but we really do need research now to really get to the bottom of that. So I'll end up now just with thanking and acknowledging, really, this is a really massive team. This is the UCL and UCLH post-COVID clinic that I'm part of, led by Melissa Heitmann, Toby Hillman, and Rebecca's there, and others. And this is the Neurology, Encephalitis, and COVID MDT as well, which I co-chair with colleague Hadi Manji, who did a lot of work in HIV neurology in the 1990s, Patricia McNamara, autonomics that I mentioned, Laura Benjamin, a Wellcome-funded investigator who's looking at other viruses and has worked in Africa as well, our neuroradiologists, infectious diseases, virologists, cognitive neurologists, neuropsychiatrists, students, and colleagues. So I'd end there, and thanks again.
Thank you so much. Again, fantastic comments in the chat. I think there's far too many questions to answer in 10 minutes. So we are going to kindly ask people to reach out on Twitter as well. The very first question, I actually want to come to my co-chair, to Kola, if he is, there he is, coming back in the room. And then Kola, you're going to lead the questions from the chat and move over into Penny. So Kola, just from your experience, and I know you're doing some national chat amongst the people who run long COVID clinics, but I think one of the scariest things for people, and that's coming through the chat, is the desaturations. So oxygen saturations might be normal at rest. Someone desaturates when they have the exercise test in clinic, but are we admitting these people? And if not, why not? Are they recovering? Is it something to be worried about?
I think exercise-induced desaturation can happen in long-COVID patients, but in my experience, from what we've seen in our clinics, it does happen, but patients do recover very quickly after a 6-minute walk test. I mean, what we've seen in our cohort, you can see it mostly in those who have ITU admission.
Oh, we've just lost your sound, Kola. I don't know what's happened there. I think we've got a bad connection.
Yeah, can you hear me?
We can hear you now, yeah.
Yeah, so I was just saying, sorry about that. I was saying that, so we know that most of those patients who had ITU admission, they do tend to have exercise-induced desaturation. But we know also that most of them, they recover very quickly. So none of our patients have required ambulatory oxygen. So I think there are a lot of theory and evidence around whether there are mitochondrial dysfunction or whether patients do have deconditioning.
Oh, sorry, we've lost you again. We've lost your volume again. Sorry, caller. Can I come into Michael while we maybe have a look at your volume? Michael, there's questions about peripheral neuropathy and incidence of peripheral neuropathy, and you mentioned there might have not been high incidence, but does that include other nerve injuries? There was some questions around foot drop. What are we seeing? Is there any?
Thank you. Yes, and I can't quite see the chat while on the Zoom call rather than looking at the live YouTube. So apologies if I didn't see anything. We have seen neuropathies. We've seen those who are in ITU have compressive neuropathies. You can have critical illness, neuropathy, and muscle problems if you've been in the intensive care for a long time. And we have seen people who've had inflamed nerves after COVID. We see a lot of people who get symptoms in the nerves, so burning pain and numbness, electrical pain. And I think that's probably dysfunction of the nerves, probably due to something going on in the body, in the bloodstream again. And when we do electrical tests, we don't see that the nerves are damaged. And then we saw a handful of people, and there have been people who've had this, where they have serious inflammation of the nerves, vasculitis. So colleague Stephen Saucer in Cambridge with Ed Needham, they've had a preprint out of an excess of mononeuropathy, foot drop, and other things beyond what you'd expect for the ITU. And of course, the virus is causing this vascular problem, small vessel problem. So there could be an increased rate of that. We have to be careful, you know, we may have under-ascertained a lot of this. If someone's in the ITU, they're very sick, we wouldn't necessarily look at their nerves. But we haven't seen vast numbers. If you imagine the vast numbers of people who've had COVID, we haven't seen a substantial increase of, say, the Guillain-Barré syndrome, which Zika virus can cause, other viruses we know, cytomegalovirus, Campylobacter can cause. In fact, we saw a lower incidence of Guillain-Barré over the year, but we think maybe that's because other more common and stronger links with that have gone away with lockdown.
Thank you so much. Thank you, and thanks again for your presentation. Cole, over to you.
Hi, Michael. So do we know whether this peripheral nerve damage is linked to whether is it autoimmune problem, or is it something that is more central, there's a disconnection because of autoimmune problem coming peripherally, or is it just a decondition due to prolonged ITU stay?
Yeah, it's an excellent question. We really don't know. We really don't know. And I think what we're trying to do is do some better imaging of the nerves. So MRI has been used a lot in muscle and also nerve now. And then the gold standard with a lot of neurology is biopsy, but that's got a morbidity with it. I'm not a peripheral. We're so subspecialist in neurology. It's we can lose an overview of things. But I'm not. There are some really specialist people looking at small fiber neuropathies, skin biopsies, and again, I'm uncertain how useful those will be. But we haven't seen so far. We haven't seen many people who've needed that kind of workup. You're quite right to say things can be due to the central nervous system. I think that's where the autonomic nervous system comes in with, brain injury, concussion, people who've had concussion, where we think in research there is inflammation, but the pattern of cognitive problems and autonomic problems we're seeing are quite similar there. So we know the central nervous system can affect peripheral nerves. In one neuropathological study from Germany, we know the virus can infect the vagus nerve. We know the virus can actually infect these nerves and has been found as well. Caveats, that's really severe hospitalized patients, and we're at the beginnings of studying long COVID, I think, just because of this 9-month time lag.
Thank you so much, Michael. If I may come to you, Rebecca and Julie, very great presentation. And I'll just come to you, Rebecca, first. Thinking about breathing pattern disorder, I mean, this is a big issue in our patient cohort in long COVID. And I'm sure a lot of us are working with a lot of these patients across all our NDT. You do virtual rebreathing training, Rebecca. There's been a lot of question around, does that really work, and do patients get a lot of difference in terms of getting better from retraining, doing it virtually?
Yeah, so I mean, we've only sort of analysed data in a small number of our patients that have come through our breathing pattern retraining course, but we have used as sort of our primary measures the Dyspnea-12 breathlessness scale and the BPAT as kind of an objective measure. And in the Dyspnea-12, we saw an improvement, a median from 18 before and 5 afterwards, with significant difference and a large effect size. And for the BPAT as well, an improvement of their median 4 before and 1 after, and again, significant difference with a really large effect size. So I think there are some limitations in what can be delivered virtually. I think, those patients that we were looking at, that was kind of after just off the tail end of the first surge. And so we were really doing everything remotely. I think we're moving to a place now where we deliver most of our stuff virtually, but there does come a point for some patients that there's a real benefit from bringing them in to see them face to face and actually get them, on the treadmill and look at what their breathing pattern is doing. But the majority of the work can be done virtually. And I think with any breathing pattern retraining, the hardest bit is that first bit, is really kind of understanding what the problem is and getting used to kind of dealing with the air hunger and how to push back on that and improving your breathing pattern at rest. And once you've done that foundation work to really improve your breathing pattern, everything else kind of falls into place. And I think different in long COVID as to sort of breathing pattern retraining before with other groups is that fatigue management is essential. And you can see kind of from the slides that Julie showed how you can achieve that virtually. So there, I definitely think that it can be helpful and it can be achieved virtually as well.
Excellent. Thank you so much, Rebecca. Julie, if I just come to you, I know you do quite a lot of huge amount of risk assessment, considering autonomic dysfunction in your patient. And in fact, I like that area of lifestyle assessment score. So, I mean, that is a great way to kind of manage and assess this patient. So how do people, looking at this podcast or watching online, how would they be able to get their hands on how to be able to assess this patient objectively or even using the lifestyle score?
Yeah, I think it's interesting, isn't it, in terms of us opening up a whole new possible tool to help us understand what's going on in our bodies. And athletes use heart rate variability a lot to see how they respond from one day to the next. And they use, there's a variety of watches on the market, they're not cheap, that give you a measurement on a daily basis. I think the thing that we tried to do was just do a little bit more than that, than not just the heart rate variability, it was about the sleep. And so you can go and have a lifestyle assessment. It's not obviously only an NHS, and Ground and Air would be able to provide you with that. But I think the most important thing is that you have someone to help you understand what you're looking at. So, there's all very well having this information, this lifestyle, measurement things, but what does it mean? And I think that's really important, that you have the support and the expertise that goes with the measurement of this variable that potentially might help people understand what's going on with their bodies.
Thank you so much. What's you, Rachel?
Thank you, Caller. And Penny, you are going to have the final few minutes of this. We are overrunning slightly, but it's okay. You will still get a 10-minute break, everyone. Just Penny, for your thoughts, questions, experiences.
Well, thank you for the talks. It was really good to get an insight into long COVID clinics from a professional point of view, because you don't really know what's going on in the clinics when you're a patient on the outside. And I really like the fact that you focused on listening to the patients, and in particular the importance of cognitive rest was emphasized by Julie and Michael. And as an OT, that's something that I've seen really people don't understand, that you need to not fiddle with your phone or watch the TV to really get rest. So that was good to see that emphasised. And we include this in our leaflets for the Royal College of OT. There's a leaflet on post-viral fatigue and also energy conservation techniques, which I personally have found very useful to use. In terms of questions, one of the things for Julie was that in clinics, quite often we use diaries to write down what we've been doing, and I for one find that really hard to do, and other people have also struggled to every day find the energy to write down what you're doing. So how do you manage that, and what do you do if they're not engaging with that?
You know what, we have to leave it to the patient and whether they have the ability to be able to complete these diaries. And you can imagine I get some people that produce an Excel spreadsheet, and then you have other people that just can't do it, and it's it's okay, it's okay, just tell us in your own words in a few minutes what this last week's been for you. So I think you're absolutely right, there's limitations, some people, but they were still able to listen to other people's stories and reflect back themselves, so it wasn't essential.
And then the other side of it is someone asked, how do you walk the line between not pushing yourselves, making sure you rest, and not deconditioning too much? And from my personal point of view, I found just keeping going a little bit, like doing gentle walks and things, was the way that I stopped deconditioning too much, to the point that then I put my back out or something. But I did have to just kind of accept that I would decondition. And I think sometimes we're scared of that, but I'm a 39-year-old normally fit person who will be able to rebuild my muscles later. That's my personal opinion, but what do you think about that question?
Oh, absolutely, 100% agree. I think that drive to not want to decondition just leads you down the path of the boom bust cycle, doesn't it? In terms of thinking, I've got to get out, I've got to do some exercise, and it gets you nowhere. So often it's the experiences, almost the failures, the weeks that have gone by where things haven't worked. I've said to patients, well, how did that work for you? It didn't work. Okay, so we need to pull back. We need to find that stability, and giving them the hope that we can rebuild, but it's going to take some time and we need to do it methodically. That's the sort of giving them hope and giving them that support of going, it's okay not to do anything, and pull back for a bit.
And then my last point really is about brain fog. Thinking about what's happening outside of the clinic. I've worked in clinics before, and the person comes into the clinic and then they walk out and they come back to the clinic later, and all those things that are happening outside, like I have a young child that I'm looking after on my own while my parents are isolating, isn't thought about. And someone did make a very good point of how do we link up with social care, make sure equipment's in place, or care packages even that people need. And I think that's an important point just to take away, to remember to refer on and try and make those transitions smoother between hospital and community services. It wasn't really a question, it was a point.
It was a comment. No, it's a lived experience, isn't it? And I think it's really important we don't forget that, because some of the things we listen to, it'll be like just trigger that thought, and that's what you've all done beautifully. So again, just to stress the point, these guys are on Twitter, social media, please reach out and DM. I'm aware we haven't answered all the chat, but also that there's quite a lot of variance. And Michael, some people are just seeing different neurological things in their clinics, and that's COVID. And that's why hopefully when the COVID clinics are commissioned for a local area, that they meet the needs of that local population of patients, that would be the best healthcare commissioning across health and social care that we could see, that's accessible, that's inclusive, with a range of multidisciplinary healthcare professionals in it. That is the blue sky thinking here. So on that note, I just want to say thank you so much, everyone. Please, you've got 10 minutes. Please do rejoin us at 15:15 if you're watching live for long COVID kids and older people.